This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in the neurosurgery department.
And I'm Dr. Alera, a research fellow. Today we're looking at a fascinating new study from the Annals of Medicine 2026. It's titled Association Between Reduced Cervical Extensor Muscle Mass and Postoperative Outcomes After Single-Door Laminoplasty in Elderly Patients with Cervical Spondylotic Myelopathy, a retrospective study.
This is a timely topic, Alara. As our population ages, we are seeing more cases of cervical spondylotic myelopathy, or CSM. It's the most common cause of spinal cord dysfunction in adults globally. We know that for patients with multi-level involvement and a positive K-line, posterior cervical open-door laminoplasty is often our preferred surgical approach. But we also know that outcomes can vary significantly among the elderly.
Exactly, Dr. Aris. The authors point out that while we've traditionally focused on bone and the degree of stenosis, we might be overlooking the soft component, the muscles. Specifically, sarcopenia, the loss of skeletal muscle mass and strength, is becoming a major predictor of adverse events in spinal surgery. This study looks at the quality of the cervical extensor muscles as a prognostic indicator.
Right. It's often difficult to get a full functional assessment of muscle strength in CSM patients because their pain or neurological impairment limits their physical performance. So using imaging to assess muscle quality is a very practical workaround. Tell us about the patient cohort and how they categorized these patients.
This was a retrospective review of 116 patients, eventually narrowed down to 101, who underwent first-time single-door laminoplasty for multi-level CSM between 2015 and 2020. They were all over 60 years old. To assess the muscles, the researchers used preoperative MRI and the Gouda layer grading system to measure fatty infiltration of the cervical extensor muscles.
For the residents listening, the Gouda layer system was originally for rotator cuff tears, but it's increasingly used in the spine. How did they group the patients?
They divided them into 3 groups based on that fatty infiltration: mild, moderate, and severe. They were 45 in the mild group, 38 in the moderate, and 18 in the severe group. The baseline characteristics like age, sex, and BMI were actually quite comparable across all 3 groups, which makes the differences they found even more striking.
Let's get into those results. What happened during the perioperative period?
The differences started showing up almost immediately. The moderate and severe groups had significantly higher postoperative drainage volumes, about 153 milliliters and 145 milliliters respectively, compared to just 99 milliliters in the mild group. Consequently, those with higher fatty infiltration had significantly longer hospital stays.
That's interesting. Higher drainage usually implies more dead space or perhaps a more difficult dissection through poorer quality tissue. But let's talk about the clinical recovery. That's what our patients care about. Did the JOA scores reflect this muscle loss?
They did. While all groups showed some improvement, the severe group had significantly lower JOA scores at the 12-month follow-up, averaging about 11.95, while the mild group was up at 14.69. Even more telling was the JOA recovery rate. The mild group had a recovery rate of 68.3%, but the severe group was only at 55.9%.
And did they look at the MCID? For the medical students, that's the minimal clinically important difference, the threshold where the patient actually feels a meaningful change.
Yes, and this was one of the most important findings. The severe group was significantly less likely to achieve the MCID for both the JOA score and the Neck Disability Index, or NDI. This suggests that even if the surgery is technically successful in decompressing the cord, the functional outcome is noticeably hampered if the extensor muscles are significantly degraded.
That makes a lot of sense. If you think about the biomechanics, the cervical extensors are the primary stabilizers of the posterior column. When we perform a laminoplasty, we are already altering the posterior tension band. If the muscles are replaced by fat, they can't support the head or maintain alignment. Did the study look at the sagittal alignment?
It did, and the radiographic data really backs up your point. They measured the C2-C7 Cobb angle. The severe fatty infiltration group showed a much greater loss of cervical lordosis postoperatively. Their Cobb angle was only 3.57 degrees compared to 7.34 degrees in the mild group.
So we're seeing a clear correlation. Severe fatty infiltration equals poorer neurological recovery, more postoperative drainage, longer stays, and a higher risk of sagittal imbalance. It's a double hit for the patient. They don't get as much nerve recovery, and their neck posture deteriorates more.
Exactly. The paper emphasizes that muscle quality acts as a key indicator of surgical tolerance in the elderly. The author suggests that preoperative MRI-based assessment of these muscles should be a standard part of our risk stratification.
I agree. It changes the conversation I have with a patient. If I see severe Gouda layer changes on the MRI, I might tell the patient that their recovery might be slower or less complete, and I might be even more insistent on a very specific postoperative rehabilitation program. Did the authors mention anything about the surgical technique itself in relation to these findings?
They focused on the single-door laminoplasty, which is generally muscle-preserving compared to older techniques, but they noted that even with this approach, the integrity of the muscle-bone unit is compromised. If the muscle is already weak, the system fails. They suggest that for patients in the severe group, we might need to consider more intensive physical therapy, or potentially even different surgical strategies, though that would require more study.
It also raises the question of whether we should be looking at nutritional status or systemic sarcopenia before we even get to the OR. If we can improve muscle quality preoperatively, prehabilitation, we might improve these outcomes.
That's a great point, Dr. Aris. The study concludes that preoperative MRI-based muscle quality assessment could guide surgical planning and postoperative rehab to help mitigate these risks.
It's a reminder that we aren't just core decompression technicians. We are treating a whole musculoskeletal system. For our listeners in residency, take a closer look at the paraspinal muscles on your next cervical MRI. Don't just look at the canal diameter. Look at the ratio of muscle to fat in the extensors. It might tell you more about the patient's future than the stenosis itself.
Well said. This study really highlights the need for a more holistic, or at least a more myocentric view of the aging spine.
Thank you, Dr. Alara, for breaking that down, and thank you all for tuning in. We'll be back next week with another deep dive into the latest neurosurgical research.
See you then.